percent incidence of difficult airway, wherein 56% of which were not recognized by the attending anesthesiologist. I am here to present the anesthetic management of a super obese patient with trisomy 21 for emergency exploratory laparotomy, biliary surgery, and common bile duct exploration. We aim to discuss the successful anesthetic management of this case with emphasis on the airway management of this difficult obese airway. A 30-year-old female was referred to our service for an emergent abdominal surgery. On pre-op evaluation, we were surprised to see a 125-kilogram lady standing 1.42 meters with a computed BMI of 61.82 kilogram per meter squared. Classified by Lake and et al. As super obese. On further inspection, she was jaundiced, had slanted almond eyes, mid-facial hypoplasia, a receding chin, very short neck, large submental fat pad, and with macroglossia and with copious amounts of oral secretions. The thyromental distance was 3 centimeters, mandibular length was 9 centimeters, and mouth opening accommodates 3 finger breadths. The neck circumference was 49 centimeters with noted midline trachea and good neck mobility. The stop bank score for this patient was 4 out of 8. She had clear and equal breath sounds. Her abdomen was globular, soft, not distended, with an abdominal girth of 188 centimeters. The intervertebral spaces were not palpable due to the thickness of fat over the back. Ancillary workups were all normal. Chest radiograph revealed an elevated right hemidiaphragm, probably positional in nature, and abdominal ultrasound revealed cholelithiasis. Down syndrome is a congenital condition most often associated with a difficult airway. Occurring in 1 out of approximately 700 births, it has a high genetic complexity and phenotype variability, often manifesting with varying degrees of obesity, cognitive impairment, and multiple congenital abnormalities. Majority of patients with Down syndrome suffering from obesity also presents with obstructive sleep apnea and difficult airway. Obesity comes with adverse health implications of multiple organ systems, most notably hypoxemia and hypercarbia, even with modest sedation, high perioperative cardiovascular complications, and the risk for aspiration. Subglottic stenosis is a feature of Down syndrome with an incidence rate 10 times that of the general population. If present, it would necessitate the use of a smaller endotracheal tube to be inserted. A smaller caliber tube, however, would result in increased airway pressures during ventilation, limiting the delivery of adequate tidal volume, consequently leading to carbon dioxide retention and narcosis. Presented with the salient features of this case, we were in a quandary on the appropriate anesthetic and airway management for this patient. The dilemma would be general versus regional anesthesia. Although regional anesthesia offers a high safety profile in terms of providing anesthesia in obese patients, it entails proper positioning, cooperation, and palpable landmarks, all of which were almost impossible to achieve because of our patient's physical stature, mental age, and level of cooperation. Since obese patients are at risk for Mendelssohn syndrome, we immediately started her on aspiration prophylaxis and venolysis was started. We have decided on doing general anesthesia and general endotracheal anesthesia based on our evaluation and consent from the patient's parents. We prepared options for difficult airway management, and our priority was to make sure that even in this difficult case, we will always have a secured airway. Upon arrival in the operating room, the patient was hooked to an ASA standard 2 monitors. Her vital signs were as follows. Midazolam was given for anxiolysis. Atropine was given as an anti-sialogogue to address the copious amounts of oral secretions usually seen in Down syndrome patients. Denitrogenation was done by giving oxygen supplementation via face mask at 10 liters per minute for 5 minutes. Propofol was slowly administered up to a total of 140 milligrams based on the patient's lean body weight. the level of anesthesia was deepened by sequentially increasing the concentration of sevoflurane without obliterating spontaneous breathing. After ensuring adequate depth of anesthesia, we inserted an LMA fast trap. The LMA fast trap was used both to secure the airway and subsequently as a conduit for fiber optic bronchoscopy in our investigation for subglottic stenosis. After confirmation of the absence of subglottic stenosis, we deemed that an endotracheal tube size 7.0 would fit. This was confirmed via bronchoscope through the LMA fast trap, after which the patient was then paralyzed with rocuronium 0.3 milligrams per kilogram. The intraoperative period was unremarkable, lasting for 225 minutes. The blood loss was 500 ml, and 2 hours from the last dose of rocuronium with spontaneous patient breathing, Sugamadex 2 milligrams per kilogram was given. With noted adequate exhale tidal volume and regular rhythm of thoracic breathing, the endotracheal tube was removed. However, the LMA was left in place, serving as an oral airway until she voluntarily cuffed the LMA. The patient was transitioned to the recovery room with intact airway reflexes and comfortable with the following post-operative analgesics. Up to this time, our patient's difficult airway was continuously in the capable hands of our anesthesia team. In conclusion, the management of patients with Down syndrome, especially the super obese with difficult airway, starts with proper planning and preparation for expected physiologic changes, possible complications, and unexpected situations. The use of LMA fast track in this case proved to be effective in establishing a secured airway prior to intubation, and also as a diagnostic adjunct by acting as a conduit for fiber optic bronchoscopy in the investigation of subglottic stenosis. Thank you for listening.